they're really worried that radiation is going to be painful. So they come in for that first day of treatment very anxious. With our brain patients, we're using the masks on the table, and those masks are very tight and hold their heads very, very still. So they'll be very worried about being claustrophobic. We may start out the first day or two with a little bit of Ativan, and they'll come to me and they'll say, this really hasn't been as bad as I thought it was going to be.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Catherine McCluskey, Radiation Oncology Staff Nurse at Atrium Health Wake Forest Baptist in Winston-Salem, North Carolina, about radiation side effects in central nervous system cancers. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation we've linked in the episode notes. Welcome. Thanks so much for joining us today, Kathy.
Well, thanks for having me.
Can you provide an overview of just how radiation therapy is typically used to treat CNS tumors and how that approach may differ when treating primary versus maybe metastatic disease to the CNS?
So there is a big difference between primary CNS tumors and metastatic lesions. And primarily, the difference is that we're pretty much limited to external beam for primary cancerous tumors like glioblastomas, astrocytomas versus metastatic lesions, which we do gamma knife. They can do glial wafers that they place that deliver radiation directly to the cavity. That's typically not a first-line treatment for primary CNS tumors, but can be for metastatic tumors to the brain. Those are the primary differences between a primary tumor and a metastatic tumor. With primary tumors, glioblastomas, astrocytomas, all of those types of cancerous primary CNS tumors, the tumors are not very well defined. They have little tentacles that kind of go out. So doing something like gamma knife, which is very precise, is not as effective as external beam, because external beam will deliver radiation to all those little tentacles that are out there in the brain. And where gamma knife, you really can't effectively do that. Those are the biggest differences between the primary tumors versus the metastatic tumors.
For nurses, I'm just trying to kind of frame my own understanding because I do not have a clinical background in radiation oncology. So I'm always learning on these episodes where we talk about radiation, and I love it. So before radiation begins, what would be the most typical baseline sort of pre-treatment assessments that nurses should be performing? And are there any specific tools or grading systems or things that we should use to evaluate any sort of baseline measurements?
I don't know that there's any specific tools for baseline that is specific to CNS radiation. Anytime you are evaluating a patient, particularly a new patient prior to treatment, you're going to obviously check baseline vital signs. We're going to evaluate for mental and emotional health. They fill out a distress screening form when they come in. I always ask about worsening sadness. If the patient indicates to me that they're struggling with sadness, depression, anxiety, I usually do like a PHQ-9 just to rate them on that. I always get a baseline CTCAE, which is the screening that we use for our toxicities. And we get a baseline when they come in before they start treatment, just so that we can be aware of any major changes as they go through treatment. But that's primarily just reading through their chart, knowing what their pre-existing conditions are, anything that might be an issue during treatment, like are they diabetic? Are they on steroids? Have there been recent mental status changes, just so that we can keep an eye on that? just the baseline so you know if there's been major changes during treatment.
What would some of maybe the typical with somebody with a known primary CNS malignancy, are there any symptoms or side effects that patients typically have as they're starting therapy as a result of their disease? And are those the kinds of things that you would sort of assess and do that sort of baseline grading of? And what are those types of symptoms that patients might come with related to their cancer?
A lot of that's going to depend on where the tumor is. Frontal lobe, is executive function, cerebellum is balance, things like that. So I usually try to, before I meet the patient, go in and look at their chart, see where their tumor is, see what their presenting symptoms were. A lot of times, especially with our primary brain tumor patients, they've been very, very healthy until all of a sudden they're not. They'll come in with confusion, vision issues, weakness or numbness on one side. They'll come in with headaches, difficulty forming sentences or finding word, just depending on where the tumor is. Usually they'll come in with some presenting symptom. They'll be diagnosed with a brain tumor. They go to surgery. Neurosurgery is called in. They go to surgery. They either do a biopsy or they'll do a gross total resection. They'll try to remove the bulk of the tumor and do the biopsy off of that, get a diagnosis. By the time they get to us, they've already had all of that done. And they have been put on steroids. The first thing you do when you have a patient come in with a brain tumor, then they have resultant cerebral edema, is to start dexamethasone. And so most of them have been on a course of dexamethasone, and a lot of those symptoms have already resolved. But I try to know what their presenting symptoms were, because once we start radiation, if they have swelling at the treatment site, which most of them will, typically what you're going to see is a return of those presenting symptoms. Most of the time, what we do for that is just go ahead and start them on a course of steroids. Typically, they'll stay on those steroids at some dosage, and that may go up and down throughout their treatment, depending on what their symptoms look like, until we finish.
That's very helpful. I mean, I think just listening to you kind of walk through the patient's typical journey, as you said, they've already been through a lot. By the time they get to radiation, they've often had at least a biopsy, if not a larger surgery. And so they may not still have the presenting symptoms that they first had at diagnosis. But as you said, still knowing what those were, or at least being able to measure kind of what level they're at now, sounds like a very important baseline to be aware of so that it can be a useful way to monitor sort of their response to treatment or their response to sort of the side effects the treatment can create.
Yes. And I also like to involve the family members, especially if they were present when all of that happened, just so that they can help me understand what's resolved and what hasn't. Because sometimes a lot of times, in fact, most of the time, the patients don't remember a lot of what happened. So the family members are a good resource as well.
So let's talk a little bit now about some of the acute side effects that the radiation itself can actually cause. What are some of the most common acute side effects that you typically see for patients if they are receiving radiation for their CNS cancer?
Well, when we're doing radiation to the brain, fortunately, there aren't that many acute toxicities involved. Sometimes they'll have some mild dermatitis. Usually it's not very significant. They, like everyone else who gets radiation, will have fatigue. Usually, once we get to the end of the second week of radiation into the third week for our primary CNS patients, the hair loss, they'll start to notice hair loss just in the treatment area. But those are the things that we see most. Sometimes we'll have patients that will experience some nausea, maybe a few headaches, but really the acute toxicities are not severe typically with our brain patients. With our spinal cord patients, a lot depends on where we're treating along the spinal cord. If we're higher in the cervical spine, they may have some sore throat, some dysphagia, some difficulty swallowing. Most of the time, or if they're in the upper thoracic, it can be similar to the lung cancer patients or the esophageal patients. They'll get some esophagitis, and we just treat with your typical like Carafate or a PPI for that. And again, usually if we're much lower than that, then we don't see a lot of side effects for the spinal cord. unless we're doing total CNS, like we're doing brain and spinal cord, sometimes we can see some dermatitis on the patient's back where it exits. And you'll see just kind of a line of redness all the way down the middle of their back. Those are the most we typically see.
Take home message for me is you have to know the underlying anatomy. Where is the radiation targeting? And so, what part of, if it's the spine, well, okay, what functions does that area of the spine serve or innervate? And then, same for the brain. It's like, well, what functions are in those parts of the brain? So, it does reinforce the importance of remembering what we learned in our anatomy and physiology classes way back in nursing school.
Absolutely. And I hung posters on my wall at my desk. It's my cheat sheet. So tell me again, what does the what does
Right? Follow
what
the cranial nerves down and which ones do what. We learned it for a reason, and now we're getting the
Good.
application for knowing that. So it all
That is right.
comes together. So when we are caring for these patients who may be having some of the side effects you mentioned, are there any different ways that you assess those symptoms? Any different tools or grading scales that you use? Or is it similar to what we talked about earlier with any of the upfront or baseline symptoms that they might be experiencing?
For their acute symptoms, we just utilize the CTCAE. I know there's several that are similar, but that is the one I'm most familiar with.
And again, that's important. I think, as you mentioned, it kind of emphasizes the importance of using a standardized scale as both baseline and then as symptoms present. It allows you to show what is changing and to what degree things are changing. If we're using just general kind of description without tying it to some sort of consistent scale underneath it, then it can be hard to really understand how much worse are things getting potentially or better. But, again, we're watching for the toxicities, we're watching for the worsening of things. And so by using CTCAE or some other consistent grading scale, that's really what allows us as nurses to, I think, most accurately describe what the change is. So it's really important for nurses to understand what scales are available to them. A lot of these are now embedded in their electronic health records. And so certainly understanding what tools, grading scales should be used is important for each nurse to know about at their own unique site of practice.
I appreciate having that in our electronic record because I can go back and look and see their progression because they're all right there at every on treatment visit, what they said last week, what they said the week before. And I can often just say, well, last week you said it was this. What would you call it? What would you say it is this week? And that's also very helpful too.
In terms of the acute side effects that might be experienced by patients, what preventative strategies or management strategies, whether that's pharmacologic strategies or non pharmacologic, what do you typically see and use for radiation in the CNS?
We use a lot of dexamethasone. That's like that's the first kind of the first line for anything that we think might be related to swelling. New or worsening headaches, especially headaches that they might notice they're waking up with consistently every day, or weakness, or new and worsening nausea, vomiting, things like that. We do a lot of dexamethasone. Most of the time, it doesn't take very high doses of dexamethasone, just a little bit, maybe 1 or 2 milligrams in the morning and one in the afternoon. And that will typically treat their symptoms very well. Of course, when you are using dexamethasone, then you sort of open up a whole new can of worms with sleep. And if the patient is diabetic, then blood sugar issues. But we deal with those as we have to. So the headaches and the signs and symptoms of swelling is usually dexamethasone. The fatigue, I tell patients to just listen to their bodies. We don't want them to be sedentary and we want them to go out and continue living their lives. But I do warn them that the fatigue is pretty much common to all radiation patients at various degrees, depending on the patient. I just tell them to do what they feel like doing. And then when they're tired, to rest. And if they find themselves having a nap in the afternoon, that's okay. Usually for skin with CNS, we recommend a moisturizer. And a lot of people use the Aquaphor, but nobody wants to put that in their hair because it makes your hair really greasy. So we typically tend to tell patients to shampoo with a mild shampoo a couple of days a week and avoid blow dryers or heat or anything that's going to dry their skin. And then if their skin is getting dry or irritated, they can use a mild moisturizer like Lubriderm or CeraVe or Aveeno that doesn't have a lot of scent to it or chemicals, and just put it on their hair. We do ask that they not do it within a couple of hours of coming in for their treatment. So they can do it after treatment, at night before they go to bed, things like that. If they're having a lot of itching, because sometimes they can use just an over the counter hydrocortisone cream or Benadryl cream to try to help with some of that itching as well.
I think that's really helpful just to understand all of the pharmacologic and non-pharmacologic options that are available when we are working with our patients if they do experience some of those acute side effects that you mentioned. Let's pivot now to chronic or late effects that we can see. What are the typical effects associated with radiation or CNS cancers that might show up shortly after treatment has ended or even later, weeks, months later after the end of treatment?
Most chronic and late effects of CNS radiation usually show up months or decades after patients finish treatment. I think the biggest thing is, just kind of radiation induced cognitive decline. I think the statistics are it affects 30 to 50% of long term survivors. They have slower information processing, shorter attention spans, sometimes executive functioning issues. Occasionally, patients can develop radiation necrosis, which is dead brain tissue that can develop just a few months up to 4 years after treatment. They may have headaches, seizures, cognitive deficits, vocal weakness, or sometimes it's hard to tell the difference on an MRI scan between the tumor and the necrosis. So that usually takes a little bit of work to ferret out. I think the biggest thing that patients will tell you is that they have worsening short-term memory, and that's pretty common across the board. And they may note that even at the 1-month follow-up, they'll say they're noticing that they're having some short-term memory issues. But I want to say I've been doing this for like 7.5 years, and our patients that we've seen long-term haven't seen a lot of radiation necrosis. I think the biggest thing that I have noticed is just the memory issues and the cognitive decline over time.
I'm sure not unlike every other cancer diagnosis, if a patient has experienced certain symptoms at diagnosis and then later on after therapy, pretty much any symptom or side effect they experience, there's the fear, the concern that this is related to my cancer returning,
Always, yes.
but it's very often could be similar to the symptoms that we might see with these late and long-term effects from the therapy itself to treat the cancer. And so I'm sure this is, if not more so, concerning for our patients who have received radiation for brain or spinal cord types of cancer presentations, of just knowing that any sort of new symptom or side effect that pops up, especially when it concerns your memory, headaches, things that they might have experienced early on, I'm sure that creates lots of distress for those patients.
It really does. And their family members. I have found that with these patients, a lot of times the patients themselves, they don't have as much distress as their family does, their spouses in particular. So it's, again, we're treating the patient and their family. They're all part of this journey. So any symptom, any little thing, it is very upsetting to patients. We hear from them frequently. We do move up MRIs sooner, things like that. But it's very stress inducing for people.
Now, is there anything in terms of whether it's the treatment or treatment planning or any other interventions that we can use to help prevent or to manage the chronic and late effects that you mentioned?
I know one of the things we do for just trying to prevent like preventative strategies for long term issues, for like radiation induced cognitive decline, we will often do hippocampal avoidance whole brain because the hippocampus is your brain's memory center. And so if we can avoid the hippocampus during whole brain radiation, then sometimes we can preserve memory and cognitive function. If we can, we will do stereotactic radiosurgery. In our case, we do Gamma Knife here at our center. We also do SRS we have one of the external beam machines, one of our Linacs that we can do SRS for patients who, for whatever reason, are not a good candidate for Gamma Knife or would prefer not to do Gamma Knife. And that, the great thing about Gamma Knife, it is so focused. The radiation is so focused that there's very little damage to the healthy tissue. The radiation is focused directly onto the tumor itself. So we don't see as many long-term effects from that treatment. Sometimes the physicians will prescribe memantine, which is an NMDA receptor antagonist, and we'll do that during radiation and after radiation. That can delay cognitive decline. So that's a medication that we can use to try to prevent necrosis. A lot of that's treatment planning, just really using strict constraints when the dosimetry. And then we can manage with steroids or bevacizumab. A lot of times we'll use if we're having a lot of swelling, they can use that to try to reduce the swelling. Sometimes they'll do the laser interstitial thermal therapy, and hyperbaric oxygen. But I've never actually had a patient that they've done the hyperbaric treatment for. But that is also an option for radiation necrosis. Most of it's a dose related kind of thing, and it's a treatment planning issue where they need to just try to, as much as possible, limit the amount of dose to the healthy tissue.
One topic we try to be intentional about discussing is the idea of sexual health and how we as nurses really are in a unique position in our relationships with patients to be able to have the conversations that maybe don't seem relevant or maybe don't seem as consequential. But I think we recognize that sexual health is part of whole patient care. We intentionally bring this topic up for all of our site specific podcast topics. So while it might seem sort of kind of a little bit out of place. Like, why are we talking about sexual health when we were first talking about radiation to the brain and spine? But I think we recognize that as something that isn't as often talked about. And so we bring that question up intentionally on this podcast because we do want to continue to raise and highlight the importance of nurses having these conversations with patients, opening the conversation for patients to discuss these topics because they can be sensitive and they can be uncomfortable. And so, how do you see the topic of sexual health, and how do you bring that up with your patients who are receiving radiation therapy for their CNS cancer, whether it's brain or spine? And how do you think nurses and other healthcare professionals can help to address the potential sexual side effects that might come from their treatment?
That's an interesting question. And I thought about that when I was reading through your list. And I thought, it's a great question. But I'll be honest with you, I don't think that is a topic that we discuss with our brain patients that often. And I can't recall ever having a conversation about sexual health with a patient, but it would make sense. I don't ever say anything about sexual health specifically, but I do make sure that I let the patient know that there is nothing that they can't discuss with us. I think that brings up something that I may have to discuss with my doctors and find out if they have those conversations, because if they do, I'm not privy to them. But I really honestly have never had anyone bring that up.
Well, and I appreciate your honesty and your candid response to that question because I think that is a common reality. And I say that's okay in hoping that nurses, when they listen to these podcasts or hear this question, if their answer is the same as yours, that I hope that they feel like that it's okay, that maybe they're not doing it now, but exactly as you've mentioned, like, let's take that back. Let's take that back to the team. Let's ask as a team, like, how are we addressing this? Is there an opportunity for us to address this in a different way? Or, as you mentioned, there are many partners in oncology care. And so, do we all need to talk about it all the time? Maybe not. But if nobody is, then somebody should. I guess is the take home message.
I agree. I really had not given that topic any thought until, I read your question. And I thought, wow, that's a really good one. So we do need to talk about that. I do a lot of referrals to our cancer patient support services and counselors upstairs. And I know that is a topic that they address regularly, particularly with their younger patients, because they may want to do egg retrieval or sperm bank if their treatment's going to affect their fertility. And so I know that is a question, and that is a subject that is dealt with our AYA population. And I do have those conversations with my AYA patients, but not with my older patients. And that needs to be addressed. So I will take that back.
It's okay in the sense that I think so many of us are in that same space where it's when we have the opportunity to pause and reflect on this topic and this question. I think for many of us in practice, maybe that is the reality. And so recognizing it is sort of the first step to making it different and making it better. And ultimately it comes down to creating that care that aligns with what is important to the patient. This is just an opportunity again to help the patient. As I think you stated so well of that ensuring the patient feels comfortable bringing anything to their nurse is underlying all of this. So whether it's a specific side effect, and certainly sexual health can be sometimes a delicate topic for certain patients or certain generations, not to stereotype, but I think those are some of the variables in play. But I think what you said underlies all of that is that we want the patients to continue to feel comfortable that they can bring anything to us. Even if we don't have the answer, we don't have the single solution, we'll help find it. We'll help them get referred to maybe the clinician or the team that is best positioned to care for what the issue might be. So that in itself is ultimately the solution that we're after. So making sure that your patients continue to feel that way in your care is ultimately what we're after. So good job for that.
No, absolutely. What I find with these patients in particular is that a lot of times their first symptoms related to any type of cancer are CNS symptoms from brain metastasis. Our lung patients, our melanoma patients, they come in through the emergency room for altered mental status or seizures or something like that. They find a mass in their brain, and then they find a mass on their lung, or they find masses everywhere. And typically they want to treat the brain masses first before they start them on any kind of systemic treatment. And so they'll come to us and they're in shock. Everything's happened very quickly. They haven't had a chance to really catch their breath. They're overwhelmed. And so I try to make sure they understand that everyone that they see here is part of their team and is with them through this journey, and they're not alone. And I do tell them, I may not have the answers, but we'll find and get you where you need to be. And I find that that's so important for these patients because they're terrified. I really feel a lot of compassion for them because it is terrifying for them.
It's very overwhelming, but I think we as oncology nurses, after, as you said, you've been 7 years and me many more, that's what keeps us here, is recognizing that, no, we can't fix everything. We don't have all the answers. We can't promise cures, and that's not what it's about. It's about filling a gap and serving a need for patients when they are feeling their most vulnerable and scared, and being able to be by their side and point them in the right direction and provide them that support. To me, that's the heart of oncology nursing. There's lots of science and everything that lives on top of all that, but underneath it all, I think that's what we offer our patients, is that safe place to ask questions and not be sure and have fears, but they can bring those to us and we will kind of help guide them through it. So the way you describe being that safe place for your patients is what it's all about. So thank you for sharing that. Well, Kathy, thank you so much for joining us on this episode. I think we've covered a lot of really great topics, and certainly maybe a diagnosis that not all nurses are familiar with seeing, especially not in the radiation scope of their treatment. So I really appreciate you bringing your knowledge and your experience to our discussion today so that we can all learn from that. As we reach the end of our episode, we'd like to always run through a series of some quick questions just to help summarize some of the important points that we've talked about. So to start that off, how do you think healthcare professionals should evaluate maybe some implicit bias or a hidden bias that they might hold just about what radiation side effects and CNS cancer really mean?
I think it's just important to step back and remember that they may have some effects of their tumor that are not easy. I had a patient the other day came down as an inpatient who we were starting kind of an emergent whole brain, who was very confused and trying to climb off the end of the stretcher and thought he was at home, just that kind of thing.
I think sometimes we see a patient and we see their diagnosis and we make assumptions on how that maybe one patient we worked with behaved a certain way or presented certain challenges. And we can easily make a jump in assumption that every patient could be that way. So I think your example is well taken of just, give each patient the individual attention and unique approach to their care that they deserve, because every patient is unique. What would you say are some common misconceptions about radiation side effects and CNS cancer?
You always get the question, am I going to be radioactive? I think that's just universal. So I try to make a joke and just say, well, we haven't had anybody turn green and rip off their clothes yet, but just reassuring patients that they are not radioactive, that they are not taking the radiation with them when they walk out the door. A lot of our patients are very concerned about losing their hair. They are afraid they're going to lose all of their hair. That's not generally the case. They usually just lose some of their hair on the side that we're treating, and it comes back. it starts to come back usually within a few weeks of finishing treatment. That's one of the big is the hair loss. Am I radioactive? And I think it's true for anyone. They're really worried that radiation is going to be painful. So they come in for that first day of treatment very anxious about it being painful. And also with our brain patients, we're using the masks on the table, and those masks are very tight and hold their heads very, very still. They can't really move. So they'll be worried, very worried about being claustrophobic, or they come in very anxious. We may start out the first day or two with a little bit of Ativan to get them through the treatment, but the vast majority, and I'm going to say probably 90% of those patients that come in very anxious about it, get through the first several days, and they'll come to me and they'll say, this really hasn't been as bad as I thought it was going to be. And they don't require anything else. They come in, they get on the table, they're on the table for 10, 15, maybe 20 minutes, most of them. And they get up and they go and they're fine. But there is that fear of the radiation itself.
What's something about this topic that's not often discussed, but you wish people knew more about?
A lot of times, I think just the anxiety that this treatment can produce in patients and just the anxiety that follows them. They start out 3-month intervals, follow up treatments. And then if everything looks good, they go 6 months and then they might go to a year. Just that anxiety that patients feel coming in for follow up scans, the anxiety that patients feel when they stop treatment, when they finish their treatment. So when they've finished their course of concurrent radiation and chemotherapy or whatever they're doing, once it stops, that anxiety they feel walking out the door that first time, that's okay, so now what? Now what's going to happen? That we're not treating this anymore. And I just don't think that it's a conversation that we tend to have a lot, but I do know that it is a real fear that patients have. I try to address that with patients too, and to let them know that just because they're walking out the door, that doesn't mean that we stop being part of their team, that they can reach out to us at any point if they have any questions or concerns and let us know.
What additional training or education do you recommend that oncology nurses seek out to stay current on this topic about radiation?
Oh gosh, just do your CE. The ONS puts out that list of different articles that you can read. I will say too that just from my own experience, this is totally out of my comfort zone. But a couple of years ago, ONS put out an email asking for people to volunteer to do a delineation study about the feasibility of doing radiation oncology certified nursing exam. And I just on a whim responded to that email. It's not something I've ever done before. And thinking that I would not be put on the team because, I've been a nurse for 37 years, but I've only been in oncology, and I'd been in radiation oncology for the last 7.5 at that point for like 5. And I thought, I don't have enough experience. I don't know what I'm doing, and they won't choose me. And lo and behold, they put me on this role delineation study. I got to fly to Pittsburgh. I had never done anything like this before. I have met so many incredible nurses with all kinds of experience. I've learned so much. It has opened up a lot of things for me, and it's been really exciting. So all I can do is say, take advantage of those opportunities when they come. Don't think that you don't know enough, because you know more than you think you do. You will learn so much and you will meet the most amazing people and get to have a lot of experiences. And so just take advantage of those opportunities when they come. I mean, it's just been kind of a neat journey for me because my background was labor delivery and maternal fetal health. And I just kind of fell into this accidentally about 7.5 years ago. And it has been one of the greatest things I've ever done. I love it. It's not easy. It's a huge learning curve. It was a huge learning curve for me. Radiation oncology has a whole different language, even. I mean, it's just completely different than really any other kind of nursing. I adore it. I consider it a privilege, just like I did when I used to do labor deliveries. This is a part of someone's journey that is a privilege to accompany them.
You're our testimonial for volunteers, for ONS, for oncology nursing at large.
And just keep doing it and do things that you don't think you can do.
I love it. Final question, are there any additional resources that you would recommend either for use with patients or maybe even other healthcare professionals who just want to learn more about radiation?
If you're a nurse and you're in radiation oncology, definitely look into taking the radiation oncology certified nurse exam and follow the outline and the study questions that they give you and go for it. Do it.
We'll be sure to link any of those resources that you mentioned, specifically about the ROCN, preparing for certification. If that's a pathway that you find yourself on, we'll be sure to link as many of those in our episode notes as we can. But thank you, Kathy. Thank you so much for joining us and sharing your time and your knowledge with us. I really appreciate it. It's been a great discussion, and I hope you've enjoyed yourself too. Do you have any final comments to share with our listeners today?
Thanks for having me. This has been, like I said, a new experience for me. So it's been a lot of fun. I've enjoyed it. It's been great talking to you. Just keep taking good care of your patients.
Wonderful. Well, thank you so much.
Take care.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.